I'm so glad you were able to come today to our program
Do that.
to hear Dr. Richard McCallum talk about cyclic vomiting syndrome. My name is Mary Angela De Grazia De Tucci. I'm a longtime motility patient, and I'm also humbled to volunteer for the Association of Gastrointestinal Motility Disorders, or AGMD. Our organization serves as a resource for GI motility disorders. It also is a clearinghouse for those in the medical, scientific, and nutritional communities. And of course, it is a form of support for patients and their families. We are so honored to have Dr. Richard McCallum here today. Dr. McCallum, the eminent GI motility doctor, he has been with our organization since 1991, which is the inception of AGMD. And he has been dedicated to our organization from the very, very beginning and in so many incredible ways. So, Dr. McCallum, thank you so much for being here, taking the time, and for your dedication to AGMD and all your patients. Dr. McCallum, can you just talk to the audience and inform them a little bit more about your background?
Sure, Marion, it's great to be with you again and continue to be part of your organization. Yes, I've been doing GI motility research for probably 40 years. And I could, Patsy, I have to call you back. Okay. And I particularly want to, let me just finish up this telephone call here. Hang on. All right. As I said, I've been involved with GI motility research for about 40 years, and particularly recently with the NIH, we focused on the entity of gastroparesis. But I see patients with nausea and vomiting from all causes. Actually, I just left my clinic and a patient came to me from Lubbock, Texas, with this classic story that fits the condition I'm going to talk about today, called cyclic vomiting syndrome. Another cause of vomiting, which is often misdiagnosed and not treated properly. So let's review this again. Cyclic vomiting syndrome has been around for quite a while. Go back into the 1800s, particularly with Dr. G, who was a pediatrician, and in England, it was initially thought to be a pediatric disorder. It's increasingly been seen in adults to the point that now it's diagnosed more in adults than in pediatrics. But we do have some rules of the road. And so we try to adhere to some kind of predictable story that can be identified by many physicians. We want some of the following points. They're predictable, stereotypical episodes of vomiting. Onset is acute, and duration is usually up to but less than a week. Usually there's 3 or more episodes in a year before we diagnose it, but typically it's up to once a month or more because the episodes begin to coalesce or get closer. Between attacks, patients look good. Eating normally, they may maintain their weight because they catch up between attacks. But dramatically, there's an onset of nausea, vomiting, and abdominal pain accompanies this situation. Diffuse pain in the abdomen, and it occurs with the nausea and vomiting. Another important history can be migraine headaches in a subset of patients. Migraine is a major precursor of the cyclic vomiting attacks. We look at 4 distinct phases. Patients feeling well. Then there's a very brief period, maybe hours, where there's sweating, pallor, and you feel like you're going to vomit, intense nausea, and then vomiting begins. This can be up to 20 or 30 times a day, even going into dry retching and going on for 3 or 4 days, often ending up in the emergency room. And then there's a recovery phase where the patient's vomiting decreases, liquids are tolerated, and nausea improves after 5 or 6 days or a week. That tends to happen. So people feel well for periods of time. Sudden onset of nausea for an hour or more, few hours before vomiting begins, abdominal pain, and continuous vomiting for 3 or 4 days or longer, and then a recovery phase. So abdominal pain often requires narcotics for relief, but can be quite severe and can lead to many diagnostic tests, CT scans, and whatever else to try to find out about the pain. The duration we talked about. Between attacks, as I said, you're relatively asymptomatic. Some patients may have intermittent indigestion, irritable bowel syndrome, maybe some abdominal cramps or loose stools, constipation. There's a history of multiple ER visits and hospitalizations. Could date back months to years because they're not diagnosed. The patients come to the emergency room and they're told they have the flu, or they have food poisoning, or they have unexplained stress or something, and they get sent home and they keep coming back and back, and no one makes the diagnosis. Menstrual cycles can sometimes be blamed as well, migraine and stress. So this delays the diagnosis for years, often. Over time, the attacks do begin to get closer, maybe from every couple of months to once a month or every 4 to 6 weeks. And this can become confusing because as the episodes coalesce, the patients may be diagnosed with gastroparesis. However, gastric emptying in CDS is normal. When it's studied between attacks, it's normal. If anything, it's slightly rapid, actually. Patients have a unique relief pattern. They find relief with hot showers, hot baths, particularly, and sleep if they can get to sleep. So one of the treatments is sedate the patient with certain medication. And now, probably 10% of my practice would be cyclic vomiting, if not more. It's now being obviously identified by other doctors as well, and hopefully patients are not waiting as long to be diagnosed. Unexplained nausea, vomiting, abdominal pain. Diabetes does not have to be present, so we don't have diabetic gastroparesis as a confusion factor, but diabetes can be present. So many things mimic CVS. Does a patient have an ulcer? Does the patient have gastroparesis? Is the pain caused by the gallbladder, cholecystitis? Is there an intermittent small bowel obstruction causing the vomiting and the pain? So patients end up having endoscopies, gastric emptying tests, CT scans, HIDA scans, ultrasounds, and x-rays, small bowel follow-through. Could it be something else? Central nervous system, could this be a mass or tumor in the brain? Hydrocephalus explains the vomiting and the headaches. Kidney failure could explain vomiting. Having adrenal insufficiency. Anderson syndrome. Porphyria can cause pain and vomiting. So we look at the urine, we might do an ultrasound, look at the plasma cortisol level, and look at the urine porphyrin level. Let's look at the clinical profile. These are some studies I did back in Kansas, University of Kansas with Dr. Naiman, my collaborator at that time. We had 31 patients we were following. Overall, the brief dominance of, or slight dominance of males, but they have a diffuse other problems. Irritable bowel can be present, diabetes is present, they've had gallbladders taken out because someone thought the pain was due to gallbladder disease. They can have heartburn, gastroesophageal reflux, and migraines. Marijuana use, we're going to get into. That's a major component. Anxiety, depression, stress is a major component as well. It's now about, as I said, about over 10% of my patients who come to me have cyclic vomiting. Most of all these patients are in the emergency room. Every emergency room is seeing patients with unexplained vomiting, and they're dismissed, as I said, as food poisoning, stress, migraine, menstrual cycles, and they keep coming back to the emergency room. Sometimes different emergency rooms, different doctors. So no one takes the time to put the pieces together and see that this is a predictable, frequent event. Diabetes does occur, but we don't blame it on diabetic gastroparesis, but patients can have ketoacidosis from vomiting. Migraines often beginning in childhood. Family history of migraines. About 30% of patients with migraines have a CVS. About 30% of CVS patients have a history of migraines. We talk about mitochondrial dysfunction, where there's a genetic predisposition in families. Panic, stress, anxiety, depression, some significant psychological event that is continuing, maybe a combination of events. We feel there's some dysregulation of the neuro pathways that afferent stimulation and efferent stimulation to the brain become exaggerated. And there's an overstimulation of these neuroendocrine mediators, and vomiting develops. Some patients can have an autonomic neuropathy, which may be a tip-off, and other patients that we talked about are smoking marijuana. So there's a syndrome called cannabinoid hyperemesis. It's been separated from cyclic vomiting. They're closely related, but there's subtle differences. The obvious one is that these patients are smoking a lot of marijuana daily, frequently. They also have a relief of symptoms with hot showers and baths, and that's present in cyclic vomiting, but it's also more common in cannabinoid hyperemesis, whether it's the relaxation achieved by the hot water, but that's a very predictable story that patients will tell you. Abdominal pain is diffuse, and as I said, even daily marijuana use is present. Males are more dominant, tend to be younger patients. They have negative tests as far as endoscopy, CT scans, and weight loss is not a prominent feature. So there's a condition called cannabinoid hyperemesis, which is different from cyclic vomiting. And it's an important part of the history. It's very treatable because reduction in symptoms occurs with cessation of cannabis over time. In our experience, about 30 to 50% of my patients, predominantly males, are now smoking marijuana as a cause of their cyclic vomiting. Usually it's going on for years. More recently, I'm seeing it in small amounts of time, 1 to 2 years or less. There's some data now that with the legalization of marijuana and the excessive planting and harvesting of marijuana and growing marijuana, that there's contamination with pesticides and contamination with fertilizers that are contaminating the plant and provoking more toxic reactions. It's not just the marijuana. It's this sort of trying to grow it quickly and fertilize it has changed the toxicity. Another group of patients use marijuana to relieve attacks. That may be okay to smoke it, once in a while. That's a different cause. Over 50% report resolution of symptoms when you stop it over time. But you have to treat the patient with other medicines, and I'll tell you about that. About a third did not identify a relationship between stopping marijuana use and symptoms. So those people smoking marijuana, there's also stress involved, and that's why we treat it with other things. Hot baths and hot showers are a very important part of the history, and it's important to initiate the standard cyclic vomiting therapy before stopping or tapering marijuana. You need both things to take place to make sure you get resolution. Not enough to just stop marijuana. So cannabis and its role, we believe there's a saturation of a receptor. It takes weeks or months to get there. In patients who may be genetically predisposed anyway. We think there's now toxicity with fertilizers and pesticides that play a role. It's lipofilling, so it gets stored for many months in fat, particularly in the brain. And this develops sort of pack years of accumulating marijuana metabolites. Cannabinoids, marijuana decreases gastric emptying. So in patients who smoke marijuana, they may have a better appetite, but they actually have slower gastric emptying. So smoking often daily gets cycles of weeks apart. And that's a confusing factor. There's weeks between cycles, and yet patients may claim they smoke marijuana almost daily. So why don't they have more attacks? Is there some magic concentration that has to be reached? Or do we see that patients who have attacks of marijuana also have stress? And the combination of stress and marijuana is the final trigger for the attack. Or does it take some time once they reach the saturation point in the brain? Does it take some time for the marijuana saturation to get back to that level? Acute treatments. In the emergency room, we try to put people to sleep. And in the hospital, we give them IV lorazepam. Inducing sleep and sedation decreases vomiting and pain. At the same time, we give antiemetics, Phenergan, Zofran, Reglan. Or if we have to, briefly, narcotics. We don't try to overuse narcotics emergently. So in the inpatient, NPO, IV fluids, lorazepam, 1 to 2 milligrams every 6 hours. Zofran, sometimes loaded for pain, and Benadryl IV. So we give them a full court press for 2 or 3 days in the hospital. Then we move into the long-term treatment and prevention. This was first studied by Ray Klaus back in 2006, where he found that tricyclic antidepressants were very successful at helping his patients. He also, there's been some literature on propranolol, cyproheptadine, and sumatriptan, particularly in migraines. And there's some anti-epileptic drugs, such as Capra, which is thought to be helpful. But we've relied mainly on tricyclics. And I've got a study here from 2010, way back, where we studied patients using tricyclics, usually 1 to 2 milligrams per kilogram. So we average probably 10 to 25 milligrams as starting dose, and we may go up as high as 250 milligrams at night before bed. But the average dose is probably 50 to 100 every night. And other medicines, lorazepam for anxiety and panic attacks, dicyclamine for cramping tummy pain, irritable bowel type pain, antiemetics, anti-migraine for those patients, and proton pump inhibitors in some patients. Significant reduction in frequency, ED visits, emergency room visits, hospitalizations, overall well-being is provided, and you have to reach a maintenance dose during that time. So maintenance may be 10 to 25 milligrams at night. There are some people who don't respond, about 13%. And we think in those patients, there's a coexisting risk factor we didn't address. Migraine headaches, severe depression, narcotic use, marijuana use. These factors need to be addressed to overcome the group that don't respond to high-dose tricyclics. Amitriptyline. Sometimes amitriptyline can cause a bit of sleepiness, and I use its cousin, a cousin called nortriptyline. So the highlights that I've tried to present to you is that patients have severe pain, abdominal pain, with accompanying cycles of nausea and vomiting, interspersed with weeks, periods of time when they're in remission. Marijuana's role is new and important. There's a high prevalence of severe anxiety and depression. If you take a history, these patients freely admit there's been a significant psychological event in their lives and continue. Also, there may be subsets of migraine headaches, autonomic neuropathy, and diabetes. But diabetes, this is not diabetic gastroparesis, but perhaps poor diabetic control, hyperglycemia may trigger a cyclic vomiting event. Gastric emptying is normal, maybe slightly rapid. It's important it's separated from gastroparesis. There's impressive and sustained response to high-dose amitriptyline. About 10 to 15% are non-responders, and they have red flags. They're using narcotics. They're having marijuana use that they have not disclosed to you. More migraine headaches than you were able to identify. And maybe having more stress and requiring higher doses of amitriptyline. So you sometimes have to use anti-anxiety medicines, Buspar, dicyclamine, antispasmodics, continue with backup antiemetics, and use maybe some tramadol from time to time for pain, but we try to avoid narcotics. There's increasing prevalence. Greater than 10% of patients now are coming to me for unexplained nausea and vomiting, abdominal pain. Menstrual cycles, I should mention, in women, menstrual cycles can be a trigger and can be a situation where you have to give a medicine to block menstrual cycles called Leuprolide or Lupron that blocks menstrual cycles for months. Take a shot every month, and we can find out our menstrual cycle is the major cause of your cycles of cyclic vomiting. There's a major need to educate, particularly ER physicians. ER staff are seeing these patients every day, and they're missing the diagnosis, and they're missing the chance to identify therapy and start to prevent recurrence. So I think that's my highlights for now. Mary Angela, I hope our audience feels like they've understood what I've been trying to transmit, and we look forward to some questions.
Dr. McCallum, you just answered 30 of the questions that were submitted in your program. But someone did ask about, they were inquiring if food allergies or diet can serve as a trigger. Is there any connection between the food and CVS?
No, I really haven't seen that, Mary Angela. No, I think regardless of how careful you are, every month for 4 to 6 weeks, out of the blue comes an attack. And there's very little warning except the migraines and the menstrual cycles may be a warning that you're going to have an attack. But the nausea starts, and even though you take Zofran, Finnegan, whatever else, it's pretty much unstoppable. You're going to go from nausea into vomiting, and the vomiting will last 3 or 4 days. The only hope we have is stopping the attacks, inhibiting the attacks by taking the amitriptyline, taking the tricycline.
Another person asked if the children have outgrown it, but does that mean that they won't get it later on in life?
If children don't have it?
If they outgrow it, so they had it as a child, but now they're merging into adulthood. If they outgrew it, is there a propensity to get it as an adult, even though they had outgrown it as a child?
No, mainly with migraines. If migraines were present as a child, and there's a family history of migraines, that may come back. That may be a risk factor. But otherwise, no, it should not be had a higher risk factor to come back in the adult world.
And you covered this, but just to emphasize, can a person have a GI motility problem along with CVS, for example, gastroparesis?
I think most of the time, 95% of the time, it's misdiagnosed. In other words, diabetics. I saw a patient this morning who's a diabetic, and they did a gastric emptying, which was normal, but they think it's still a diabetic gastroparesis. I think the only way we could blame diabetes is if the blood sugar gets out of control and you start going into ketoacidosis, you begin to vomit. But that's not true cyclic vomiting. So in general, no, gastroparesis alone does not make you more likely to have cyclic vomiting syndrome. No.
I see. And someone also wanted to know, does the treatment last all their lives? So they'll always have to go through this. And when the symptoms start coming, they take the medication. I'm just verbalizing.
I know. I start the amitriptyline and go up to start at 10 milligrams at night before bed, go up 10 milligrams every week until I get to 50 milligrams. Then I'll see how they do. I may have to go up to 75 or 100. When the attacks stop, I want them to continue to take the amitriptyline, the dose they're on, for a year and have no attacks. If they have no attacks for a year, I begin to taper the amitriptyline 10 milligrams every 3 months. And the only exception to that would be pregnancy. Amitriptyline is contraindicated in pregnancy. So if pregnancy were to develop, we would have to make a strategic change in our treatment. We couldn't continue the amitriptyline, but I want a year of no ER visits, no episodes, and then I start to taper the dose. At the same time, with the marijuana, the same time you try to stop marijuana, you can't stop marijuana cold turkey. They're going to stop it slowly over a period of a few weeks. During that time, I will start amitriptyline. And when you stopped it, I continue amitriptyline because I want to have a background to help you relax. Amitriptyline is an antidepressant and helps relax the brain and the gut. So I want to have amitriptyline when you stop the marijuana to help you continue to stop marijuana. And then sometimes I have to give lorazepam or Ativan because patients have a lot of anxiety when they start marijuana, or even without marijuana. Patients have a lot of anxiety, and I often have to give them Ativan orally at home as co-therapy along with the tricyclic antidepressant, along with the amitriptyline. So sometimes we do give Ativan or lorazepam to prevent anxiety attacks.
I see. Like gastroparesis, I think there must be a dental impact on this where you're vomiting 30 times a day.
Right.
There must be a propensity towards cavities or gum disease with this until probably it's under control.
Well, you sometimes vomit blood. And that's because when you vomit forcefully, you may cause a tear at the junction of the esophagus and the stomach, called a Mallory-Weiss tear. And these patients may end up having endoscopy when they get admitted. But that's not an ulcer. That's a tear from forceful vomiting. But no, it's dramatic. Dry heaving, non-stop vomiting. It's impressive. Dehydration obviously is the major concern, and low potassium levels occur. So you have to give IV fluids plus IV potassium is often required.
I'm going to open it up to see if the audience has any questions. Would anyone like to jump in? You can put a little hand signal. There's a little raised hand icon, and also just say your first name. Hi, Letitia. Can
Hi.
you just unmute yourself? There
Yes,
you go.
ma'am. Can you hear me?
We can hear you.
Yes,
Okay, so I've never been diagnosed with this. I'm diagnosed with gastroparesis, irritable bowel syndrome, but it seemed like I have this. So my question is, when I have a flare up, and when I'm constantly, and I don't vomit, I dry heave because they wrap my esophagus. To coming out of that, like it's just like the doctors are at a loss. It's like, what do I do?
uh,
Coming after the dry heaving.
so you have gastroparesis, you're saying.
Yes, sir.
And what's the cause of the gastroparesis?
They went in. It's they did a Nissan fundification at first. So he said the opening between my stomach and my esophagus was too big, and no matter what, the acid was going to continue free flowing up. So he went in to repair the hiatal hernia, wrap my esophagus, and I still was having problems. So then he said my gallbladder wasn't working right. And then another doctor said the wrapping of my esophagus was too tight. So I had two surgeons in one. One surgeon took loose the esophagus, rewrapped it, and the other doctor took out the gallbladder. When he took out the gallbladder, he damaged my nerve, which caused the gastroparesis.
Yeah, so the vagus nerve was damaged when they repaired the hernia.
Yes, sir.
Okay, so you have a vagal nerve damage, and they can lead to.
They don't say it, but I believe it is because like this last flare up, I could just feel like spasms on the inside. And I used to feel it before. I mean, I used to feel it when I used to have a flare up, but going to the emergency room, they would, they wouldn't say it was spasms. They would say it was something else. Or they just didn't know. And they would constantly just treat me with Reglan,
You can't have,
promethazine, and Zofran.
yeah, you can't have both. So between attacks, when you're feeling well, you need to make sure the gastric emptying is slow.
Make sure it's slow.
Yeah, that would
Okay.
that would make a diagnosis of gastroparesis.
Okay.
And then if you vomit on top of that, then that's just due to the accumulation of food in your stomach. So you have,
Okay. I did vomit on top of that.
are you taking metoclopramide every day?
I'm taking Zofran
No,
every day. They tried me on the different antibiotics, but I had a reaction to all of them.
no.
So I'm not currently taking anything
Well, you need
besides the nausea medicine.
yeah, the nausea medicine does not empty your stomach.
Right, it does not.
So you need to take metoclopramide
Can you spell it for me?
as a tablet. metoclopramide,
Okay.
metoclopramide.
Okay.
It comes as a spray called Gimoti, Gimoti, a nasal spray. You spray it in your nose, and it's absorbed within 5 minutes.
Okay.
Metoclopramide is called Reglan, Reglan.
Yeah,
Reglan.
they just put me on. I just got out the hospital not long ago. So usually when I'm in the hospital, they'll give me Reglan. So I had reaction to Reglan where my fingertips went numb and my lip was like trembling. So they didn't put me on it long term. They put me on it for a little while and tell me to take Benadryl with it. That's not okay.
So
But I do have some Reglan now.
what symptoms did you have?
I do. I couldn't hear you.
When you took the Reglan, what symptoms did you have?
I still couldn't hear you, so I'm sorry.
Did you have tingling or burning or tremor?
Tingling and tremors.
What dose was that?
Just the tingling, the tremors, and my fingertips getting numb. You like more tea?
Was that at the 10 milligram dose or what dose was that?
I can't remember how many milligrams.
Well, if you have a problem with Reglan, you need to take erythromycin.
Okay. That made me sick as well.
Then the only other drug is
So
called.
the antibiotics make me just like continue like dry heaving. and it make me extremely nauseous.
The only other drug left is called Motility. Motility
Oh,
stimulates the stomach and the colon.
okay.
Called Motility. Motegrity.
Okay.
Motility. That would be the only drug you could take if you're allergic to these other drugs.
Okay.
How much Zofran do you take?
I just recently cut it down, but I was taking Zofran probably every 4 hours.
Under your tongue or is it
And I
tablet?
stay constipated, so
Well, you can take some Miralax.
okay.
It's a powder.
Mhm.
But
Okay.
Zofran you can take maybe every 6 to 8 hours.
Every 6 to 8 hours.
Yes, not take it as regularly.
Okay.
But
Thank you so much for this information. Like I hadn't heard about this cyclic vomiting, and I know
Yeah.
that's I was experiencing that.
Well, do you have migraine headache?
I do have migraine headaches, and I had them as a child.
Well, migraines can cause vomiting. It's not due to so-called cyclic
Yes.
vomiting. Migraines alone can cause vomiting. So if patients have migraine headaches, we advise them to receive treatment for the migraine.
Okay.
Headaches in general, migraine particularly,
Okay.
can cause nausea and vomiting.
Mm-hmm. Okay.
All right.
Thank you.
Thank you so much. Thank you.
Thank you.
We have another question from Eva.
Hi, thank you for taking my question. I just needed a little bit of direction because I've been having major GI issues for 2 years. So 2 years ago, I had cyclic vomiting for 14 days and was in and out of the hospital. And it was determined that I also had dysphagia symptoms, and they determined that I had a slip nissen and a hiatal hernia. So they fixed it. However, since they fixed it a year and a half ago, I still have nausea and vomiting whenever I eat and almost regularly. I still have dysphagia with an unknown cause. I have a stricture in my entire esophagus. And I've lost 110 pounds. Now I'm malnourished and dehydrated. And I feel like my doctors keep going in circles, and I don't know what to be asked to test for, what medicines to ask for. I'm completely at a loss with no alleviation of symptoms. Symptoms just keep getting progressively worse.
Well, did they do an endoscopy recently on your esophagus? Have they tried to dilate your esophagus or stretch it?
I'm scheduled to see another surgeon next week, but I consulted with Johns Hopkins and Georgetown University in Maryland, and they said due to the intensity, because I have a stricture from root to tip, that they could offer me a dilation every month for the rest of my life. And I thought that that was really extreme. And they keep telling me they don't know what caused the stricture in my entire esophagus. So I'm not comfortable having surgery every month for the rest of my life if they don't know the root cause.
Well, they need, I don't think you can have a stricture throughout your esophagus. That doesn't happen. The stricture tends to be towards the end of your esophagus. It's either caused by, when you have the surgery, they may have wrapped you. They put a wrap around the bottom of your esophagus called a fundoplication. They may have wrapped you too tightly, or if you have acid reflux, acid can cause a stricture. So the narrowing would be potentially at the lower end of your esophagus. Is that where they said the stricture was?
Initially, but then when they did an endoscopy again a few months later, they saw that my entire esophagus became abnormally narrow and strictured. So that's where it initially where they saw it. But now I'm at the point where my entire esophagus is narrowed.
Well, there's a condition called eosinophilic esophagitis. And that,
They tested me for that and I was negative.
well, in that case, you need to see not a surgeon, you need to see a gastroenterologist to look at your studies. We don't see the whole esophagus narrowed. We don't see that. Doesn't happen. We see usually the distal third or so is narrowed from acid or from the wrap. And eosinophilic esophagitis is the only condition that would explain narrowing throughout your esophagus. So you need to see a gastroenterologist to go over the study and make a determination. You definitely don't want to just have surgery. There may be a role for surgery eventually if it's thought that this wrap is too tight and that the wrap needs to be undone. Do you still have acid reflux? Do you still have burning?
I do, and I take omezapyl. I've been taking it for 2 years, 20 milligrams every day, and I still have reflux symptoms.
And they theoretically they wrapped the end of your esophagus. Is that right?
Yes.
Yeah. Well, you have to start with the dilations. We go at a very low size, maybe a 10 or 15 millimeter size, and then we build up to a much higher size where maybe patients need to be dilated every 6 to 12 months. But we don't, if the whole esophagus is narrowed, the treatment is dilation initially, and B, there's a new drug that's replacing omeprazole. Let me see if I have the drug here. Yeah, it's called Voquezna, Voquezna. Voquezna is a new acid blocking drug that's more powerful than omeprazole.
Okay.
You may want to inquire about getting a prescription for Voquezna. Voquezna.
Okay. Thank you.
But you need to see a gastroenterologist first and certainly do some basic stuff. Surgery would not be in the picture if your whole esophagus is narrowed. You need
Yeah. And I've had a couple of doctors tell me, you're so severe, you need a feeding tube. And I said, that doesn't help any of my symptoms. That helps me get out of malnutrition and dehydration, but I will still have all of the issues. And I'm not willing to consent to that because if they don't find the root cause, they're just trying to band-aid this.
Have you been officially dilated yet with dilators?
No, I haven't because they can't tell me what's causing it. And Hopkins and Georgetown tell me I need dilation every month, and that's a bit extreme. I don't want to put my body under anesthesia every month for an unknown period of time.
Oh, when they do the endoscopy, do they say that there's a specifically tight area right at the junction of the esophagus to the stomach? That's where the wrap took place. Did they say that is particularly tight at that point?
Initially, yes, but now it's the entire esophagus. That's what my latest endoscopy showed.
Well, you're gonna have to, then there's gonna have to be a decision made. That doesn't happen. I see hundreds of patients. It doesn't happen. So if the wrap is too tight, it needs to be undone. A. B, if you're still refluxing, you could try this more powerful acid blocking drug. But if you don't have eosinophilic esophagitis, nothing else can narrow the whole esophagus unless you have a condition called Barrett's esophagus, where there are changes in the lining of your esophagus due to acid. Has anyone mentioned Barrett's esophagus to you?
No, but I can ask them to check it during my next endoscopy. Thank you.
Thank you.
Thank you for sharing that. Should patients go to a motility specialist for CVS, or can they go to any general gastroenterologist?
Most gastroenterologists have heard of CVS and should be familiar with the treatment. No, it's not. I wouldn't say you have to go to a motility specialist. It's a pretty well-known entity. It's been very highly publicized recently because of marijuana. The average GI person should be able to help you.
And what about primary care doctors? Is it trickling down to the primary care doctor?
I'd say very unpredictably. I wouldn't rely on the primary care doctor.
I see. Well, I think that's with some of the motility disorders too, that sometimes the primary care has no idea. But the good thing is if they can refer you to the experts in that field, that will be helpful to the patient.
About diabetes and blood pressure and other things, I think they don't know this is the sort of fine print. It's probably too much for them.
The last question that we will have time for is one patient has dysautonomia and wanted to know if CVS could go hand in hand with that.
No, dysautonomia, we see gastroparesis with dysautonomia, sometimes with POTS syndrome, which accompanies the dysautonomia. We see either gastroparesis or rapid emptying, but we don't necessarily even think about cyclic vomiting.
Okay. Anybody else have a quick question? I know. Are there any quick questions? I thank all of you who spoke today for sharing a piece of your lives with us and having Dr. McCallum be able to give you some guidance on that. Dr. McCallum, we are forever grateful. You're always so generous with your time and graciousness with all you do. And there are no words that we can say that will describe really how much you've done. I want to add that this program would not be possible without Evoke Pharma. Evoke Pharma is a specialty pharmacy, and they're dedicated to helping patients, and they are the makers of GI Modi, which Dr. McCallum spoke a little bit about today. And that's the nasal spray of the metoclopramide. So we are grateful to Evoke for their generosity in sponsoring these programs. And I always close these programs the same way. But I want to thank you and know that you are my heroes, including Dr. McCallum, but you're all my heroes. And Evoke Pharma is our hero because Dr. McCallum and Evo, they are working to help patients in so many ways. And that to me means so much as a patient myself, that there are doctors who are trying to address symptoms, trying to research it, and trying to provide hope for patients. And for you patients, you are my heroes because every day of your life, you are going through this. You have to make decisions that impact your life on, do I do surgery? Do I do this test? Do I do this procedure? What do I have? And you live a lot of your life in if onlys. What if I do this? What if I can't go? All that makes you the quiet hero. You hear about actors, actresses, sports stars, they're all heroes, but you are the ones who really are the stars. And for all of you, know that you may feel alone, but you're not alone. My heart remains with you every day. My thoughts are with you every single day. In my prayers, whether I've met you or not, I am praying that perhaps you'll have some relief and perhaps this can be one of your better days. May God bless you all. Thank you so much again, Dr. McCallum.
Yes, well, I'll be going to the annual GI meeting in May. So our next podcast will be in June, where I'll bring you an update on what's new with GI motility based on the presentations at the annual GI meeting.
Very exciting. Thank you again. Thank you so much. Take care. God bless.
Yes,
Bye-bye.
Thank you. Thanks, Angela. Bye-bye.
Bye.